started. I am Ashley Haltom. I'm the VP of Government Affairs for Georgia Bio, and we are thrilled to have you for our second installment of the Patient Advocacy Alliance Roundtable discussion. We've got a great rundown for you today, but before I turn it over to Holly to introduce our speakers and speak a little bit about the Alliance, two quick things. One, while you are on this recording, please be sure to keep yourself muted while the speakers are speaking. We will have an open discussion option at the end. And if you do have questions, feel free to put them in the chat box. Our speakers will see them, we'll make sure that they do, or you can open them up, you can ask them, I'm sorry, once they are finished with their presentations. The second is that we will hold our second annual Patient Advocacy Summit in September. Still nailing down the exact date, either September the 16th or the 17th. We will have our first planning committee meeting next week. So thank you to those of you who are serving on the planning committee. That being said, if you have speakers or topics that you would like covered, please either put those in the chat or email me directly, and we will do our best to highlight those and to get those speakers for the event. And with that, I will turn it over to our Advocacy Alliance co-chair, Holly Snow.
Hi, good afternoon, everyone. Thank you for participating in this important meeting. Just to refresh everybody's memory, this is our second roundtable discussion. I was asking a few folks before the call. I can't remember when we first started the outreach of working with the patient community, because clearly from a manufacturer or provider standpoint, we all need to be rowing in the same direction for us to have success, because at the end of the day, the patient needs to be number one, and we need to make sure that we're all supporting policies that will move the needle. And so I'm just very, very thankful that Georgia Bio has taken charge and put structure to this, both the summit and the workshops, and would like to encourage you all, if you know of other patient groups that would like to join and become a part of this discussion, please do so and let Ashley know. Let me start. Aiken Hatchett is not only Senior Advisor for Federal Government Relations at Bio, but she is a Georgia native and graduated from UGA with a Master's in Public Administration, in addition to a BA in History and Poli-Sci. I think most of you all may be aware that Bio is the national trade organization that represents the life sciences industry. And in that capacity, Aiken has led the organization's federal advocacy and political strategy development. Prior to Bio, she spent more than a decade in various government affairs roles within the physician community, including the American Medical Association, the Medical Association of Georgia, back in, I think, 2005, you said, Aiken, or maybe that was with Cornerstone.
Yeah.
And, which is where I first met her, and with the American College of Rheumatology. So with that, we're very, very pleased to have you, Aiken. Let's have a discussion about HR 3 and the implications it might have for the future of healthcare access. Aiken?
Well, wonderful. Well, thank you, Holly, so much. And again, Aiken Hackett with Bio here in Washington, D.C. We actually have a beautiful day outside. It's not August yet in the swamp, but it's about 77 degrees. And so I look forward to spending the afternoon outside. But obviously, HR 3 is, I think, the pinnacle of the worst drug pricing policies that are out there in Washington. But really, the holistic drug pricing debate is something that we all need to really pay attention to. So I'll talk really more about HR 3 and the genesis of how we got here. But at the end of the day, we have like a lot more things to talk more broadly about, really the bad policies that are out there, but what the industry really wants to see done. Because I think first and foremost, which is paramount, is that we want to see solutions that will actually help patients lower their out-of-pocket costs without hurting medical innovation. So with that general theme, we always have to remind lawmakers that we're not here just to say no. We are here to be constructive in the conversation. But things such as Nancy Pelosi's drug pricing plan is something that is really just untenable. So to kind of just start from the beginning, I'm gonna do the history. So in 2006, when Nancy Pelosi first became the speaker, she declared that Medicare negotiation was one of her top 6 of 6. So it was 2006. She had 6 priorities, and Medicare negotiation was one of them. So it comes down to be really the background of where Democrats really wanted to go when it came to the drug pricing debate. So this was from 2006 until, throughout the past decade and a half, talking about health policy. This is kind of where we are today. So 2018 comes around and she gets her gavel back and she's speaker yet again. So 2018 is really when the dialogue really starts on the drug pricing debate. I would say that during the beginning of 2018, we had a lot of bipartisan discussions in the key committees on Capitol Hill of really trying to figure out a way to do this together. I think we saw that really back in 2010 with the Affordable Care Act. People tried to work together, and then out of nowhere, you kind of pivot and you go down the path of politics. So at the end of I guess this is 2019, because obviously they come into leadership in the year of 19, we see HR 3 rear its ugly head. So we knew it was coming, and so us as an industry tried to do our due diligence to educate lawmakers on the devastating nature of what this is. And I'm going to state the obvious that people like to stick it to big bad pharma, but they don't actually think about what it is to impact little bio. And where we represent all the companies out there, there's a narrative that goes kind of with both of those. Anyway, so HR 3 was introduced in 2019. We have a lot of committee markups. It's a lot of focus. And at the end of the day, they had a vote, and it was all the Democrats voted for it and 3 Republicans. And technically it's 2, but with 1 extra Republican or Democrat who then eventually switched parties. So we have like 3 problem children in the Republican conference that we kind of look to in that. Anyway, so that's what happened with regards to HR 3 in 2019. But we all knew at the end of the day that Mitch McConnell was going to be the backstop of bad drug pricing policies. So I think a lot of Democrats at some point in time, especially those moderates who actually care about the industry, really looked and said, well, I can still vote for this. I'll be with my speaker. I'll be with my conference, but I don't have to go against them, but I really still care about really the industry, whether it be small biotech or big pharma. So we're always going to be fighting essentially Nancy Pelosi's HR 3. But kind of in the sense of what was going on then, we were also fighting back President Trump's international reference pricing or most favored nations. We have like 17 different variations of how we can refer to that. So we're kind of fighting on all fronts. It's almost like World War II. So we're really having to utilize a lot of resources to address that. Anyway, so to give other people landing spots, House Republicans put forth what was referred to essentially as HR 19. And HR 19 was going back to the compilation of the bipartisan effort from earlier in the year of 2019. It was all those policies put into one package. So it was more of a bipartisanship of how to really more responsibly address drug pricing, as opposed to be essentially what I would call a blunt force object to the industry, which is what HR 3 is. So the calculation kind of changes, as we go through, I guess, 2019, and also like I said, COVID happens. So, or as 2020 happens and COVID happens. So during the times of COVID, we don't have to really worry about what's going on with drug pricing, because we are really the industry that is saving the world. So we have a little bit of a reprieve of the constant attacks that we have. And you would think that all the good nature of the industry would actually be helpful during this time, but sometimes that doesn't necessarily work at all. I also probably should make note that HR 19, the bipartisan bill, also has a Senate companion out there. Anyway, so then we have the 2020 election and the political landscape changes. And I know in Georgia, as a Georgian, I don't have to tell you that that was a big deal, and a lot happened there, especially again not having Mitch McConnell as the now backstop of HR 3 and bad policies. But HR 3 is a little bit more real now, and we have to address that. All being said, the House Republicans also won back a lot of seats in the House. So as of today, I think the margins are 4 is for the Democrat majority, and the Senate, as we know, is a 50-50 split, with the White House being with the Democrats, and so they have the tie vote. So all of a sudden, we're back into 2021. drug pricing is now a new topic of conversation yet again. And so this spring, HR 3 was reintroduced. And we, I guess it was end of April when it's introduced. Beginning of May, we start having committee hearings on it. And then all of a sudden, on May 3rd, there was a secret letter that was sent by 10 moderate Democrats urging bipartisanship and addressing healthcare and specifically drug pricing. And so not to shock you, but there are no secrets in Washington, D.C., and it leaked out. And all of a sudden, the momentum behind HR 3 really changed. So that's really positive, and it came down to slowing down what was happening. But Nancy Pelosi is very talented and powerful, and she really knows what she's doing. So it's still out there as something that we need to pay attention to. But people also know in the dialogue that HR 3 may pass the House. May was a big question mark, but it can't really go anywhere in the Senate because the Senate needs to pass the 60 vote threshold. There's no way you can do that unless you're going through reconciliation, and reconciliation becomes more complicated for a lot of various reasons of what can be included in the actual policies and whatnot. When it comes down to those 10 Democrats that signed the secret letter, it was a political move by them. They don't want to have to take the tough vote. I don't know how Nancy Pelosi feels about the tough vote. I don't think she really cares at the end of the day because she just likes to get her way, and she just cares that the bill can pass. So her only calculation really at the end of the day is, can this bill pass? Anyway, so going on in the Senate, since going back to, I guess, the last Congress to now, we had Ron Wyden working with Chuck Grassley. So last Congress, Chuck Grassley was the chairman of the Senate Finance Committee, and Ron Wyden was his ranking member. With the Senate flip, the Grassley-Wyden conversations have essentially changed a bit because the political calculation is a little different now. So Ron Wyden wants to, where he and Grassley have been aligned for so long, Ron Wyden, as of yesterday, put out his principles, and his principles said, I now support Medicare negotiation, with which a line in the sand that Chuck Grassley would not go down. So the Medicare negotiation probably is really front and center of the Democrat drug pricing healthcare debate on who can support it and who can't. So with the Senate dynamics changing, and Wyden actually turning a little bit more left, those things are kind of making all the future of really drug pricing reform a more complicated thing. So we're in the middle of July. August recess is right around the corner. And so what do we have now? So we have HR 3 that's still back out there, but it doesn't really have a lot of the momentum. We have HR 19 and its Senate companion that was also introduced again yesterday, kind of the more bipartisan, although it's called the Republican alternative. Again, it's the bipartisan bills out there. You have Wyden and his new package that he put forward. And then you also have this group of, I guess it's 58 moderate Republicans and Democrats in the House called the Problem Solvers Caucus. And they're very bipartisan, and there's a 50-50 split between them, and they're working on their own proposal. And then you have that group of 10 moderates in the House as well, who are also working on their proposals. So it's almost like a choose your own adventure of where do you want to go in drug pricing. So we don't really know what the future is going to be. But as each day passes, you kind of get more and more complicated of trying to get things done. So if you have the month of July, then you have the August recess, and then you have the September 30th deadlines, and that is, funding the government, all the extenders expiring, other things that are must passes, you kind of lose legislative time to get HR 3 done. In HR 3 and or any sort of drug pricing. You also have Bernie Sanders and then the very progressive left in the House working on their own things. And so it really is, again, kind of a cluster of thoughts going on. So with that, I know I'm a fast talker. My father was raised 2 girls with my mother. And so essentially he stopped listening to me after 2 minutes, so I talk really fast. So thanks for paying attention. Anyway, so there's a lot going on in Washington. There's also there's not a lot of clarity of what really is gonna happen next. So with that, I know there's probably be some questions about really the policy in itself, and then what really can be done. But with that, I'm gonna kind of turn it back over to Holly and look forward to y'all's questions on what's going on.
Thank you, I appreciate it. Our next speaker is Carl Schmidt. And he's not only the executive director for the HIV plus Hepatitis Policy Institute, which is based in DC, but he founded the Institute. The Institute promotes quality and affordable health care for people living with or at risk of HIV, hepatitis, and other serious and chronic health conditions. In this role, he leads advocacy efforts to ensure domestic HIV and hepatitis programs that are based on sound public policy and that they're fully funded. In December 2018, he was appointed co-chair of the Presidential Advisory Council on HIV/AIDS, and he serves as a consumer representative to the National Association of Insurance Commissioners. Mr. Schmidt earned a BA in Public Affairs and an MBA in the International Affairs program from George Washington University, also based in Washington. So with that, thank you, Carl, for joining us this afternoon.
Well, great, Holly. Thank you very much. And it's good to be with everyone today. Just a little background on the HIV and Hepatitis Policy Institute and the work that we do. Obviously, we spend a lot of time on the specific HIV issues and hepatitis issues, but there's a couple things in common with those two diseases. One, they're infectious diseases. But two, thanks to medications, people living with HIV, if they have access to the medications, they could live a really healthy, long life. And now we even have drugs that prevent HIV. And then with hepatitis B and C, I have hepatitis B myself. I have to take a drug every single day, and I am doing well. I wasn't always doing well, but I am thanks to the medications. And I'm sure everyone's heard that we now have a cure for hepatitis C. I spend a lot of time on access to medications and see the difficulties that patients have in accessing and, more importantly, affording their medications. And I try to work across disease groups as well, because it's not just people with HIV and hepatitis, it's people with cancer, mental health issues, lupus, Alzheimer's. We all face the same issues about access and affordability. So I work in coalition with a lot of other disease groups as well. So I think when it comes to drug pricing, what is important to patients is how much they pay at the drug counter. People are rightfully complaining about the high price of drugs, but what they're complaining about is how much they're paying for them. And I think a lot of the discussion is in Washington is not focusing on where the problems really are when it comes to patient affordability of drugs. And so I've been trying to highlight with other patient groups some of those solutions. And I teamed up with the Autoimmune Related Diseases Association and ARDA, and we put together a letter that was directed to Secretary Becerra, because we know, drug pricing is an ongoing issue. It was big in the, as we heard from Aiken in the Trump administration, and we knew it's obviously one of the top issues in the last election. President Biden is going to continue discussing it. And so we said, what are some of the solutions from the patient perspective that we would like to see? So we put together a letter, it was signed by 124 patient groups, and we put forth, 5 different proposals. And, so the first one was making sure that the federal government and also the state governments enforce the non-discrimination protections in the Affordable Care Act. We still find that in many insurance companies are discriminated against people with who rely on prescription drugs. They still put all the drugs to treat a certain illness like HIV on the highest tier. They still, they're putting utilization management techniques on. That's discriminatory against people. And I think one of the biggest discriminatory practices that the insurance companies are engaged in is they're shifting more of the out-of-pocket costs onto the patients for prescription drugs than other parts of the healthcare system. So for example, if you go into the hospital, which is by far the largest health expenditure in the country, patients are only responsible for 3% of the out-of-pocket costs. On the other hand, prescription drugs, which are probably a third of the expenditure of hospitals, patients are stuck with paying 14% out of the out-of-pocket costs. I'll probably talk about co-insurance later, but when's the last time you went to the emergency room or a hospital and they asked you to pay 50% co-insurance? It's usually $100, $200 for the emergency room. So I feel that's discrimination against people who rely on prescription drugs. And that it all comes down to insurance benefit design. And so I think number one, to enforce the non-discrimination provisions in the Affordable Care Act. Number two is to put cost-sharing caps on prescription drugs. And this really goes with the third solution as well, making sure that there's first dollar coverage for prescription drugs. Because, we've seen a number of states enact laws that say, okay, it can't be more than $50 a month or $150 maximum a month for patient cost sharing. And states such as Louisiana, DC, Delaware, California, New York, they've all instituted these type of copay caps. And there's some bills in the Congress as well. And this is great. But if you still have a high deductible, that means you may have to spend $8,000 before before this cap kicks in. So we really have to tie it into no deductibles for prescription drugs. And, or if you do institute these caps, make sure that there's no, you don't have to go through the deduction. So, it's not, we're not saying that every state, every plan in every state has to have, copays, reasonable copays. Maybe like in Colorado, they have some of them. If you have a plan that has co-insurance, you also have to offer a plan that has reasonable copays. Because I think that these high co-insurance and high deductibles are really the barriers to patients' access to drugs, and why they complain about why their drugs are so expensive, because they have these high deductibles and the high cost sharing. So so hopefully, we're seeing some of that in the bills on the Hill for putting some caps. Particularly in Medicare, because there is no out-of-pocket limit right now. There is an out-of-pocket limit, but it's, for the private insurance plans. But, it's for a person, it's $8,000, $9,000. For a family, it's twice as that. And that's an awful lot of money, particularly if you have to take your drug in the beginning of the year. People with chronic conditions, they have to, come up with thousands of dollars right in the beginning of the year. And so that's why we recommend no deduction for prescription drugs. There used to be a lot of plans like that, and it's going further and further away from that. The other thing is that we want to make sure that copay assistance counts for prescription drugs. There's been a movement by many insurers in the PBM industry to say, okay, we'll take your copay assistance, but it's not going to count towards your deductible or your out-of-pocket costs. And what happens there is that people are shocked. They don't even know this is happening. The insurance company is taking your money. They're taking the copay assistance from the companies. And then when that runs out, they're going to take it from you. And so the insurers are actually double billing, but they're hurting you, and people don't even realize this, and they go to pick up their drug and they're stuck with a several $1,000 bill. Now, thankfully, many states states have enacted legislation, including Georgia last year, to forbid these copay accumulator policies. But when there's state laws, that only impacts, it does not impact the ERISA plans. And so that's why we need federal action to say that copay assistance counts. And there's something that the Secretary of Health can do with the stroke of a pen, but Congress can do it as well. And there's been discussion of congressional action. So the final recommendation is to look at the whole ecosystem for drugs. And a big part of that these days are the PBMs and the whole system of rebates. And I think there's some analysis that shows around 50% of list price of drugs go towards rebates. And some of those are congressionally mandated, but then there's those additional rebates as well. And the unfortunate thing is, someone is pocketing a lot of money for being a middleman. And what makes it worse is that the patient, has to pay their copay, their co-insurance and their deduction based on the list price of the drug, not on the price that is negotiated. And so that's something that we think that they should look at as well. So, Aiken talked about we sent that letter not only to the Secretary of Health and HHS and the White House, but we sent it to all members of Congress as well to give them ideas on what they can do to actually help patients. We also send it to every insurance commissioner, because they have a role in each state as well in a lot of these issues. And some states have done some ingenious things to help patients. We also asked to meet with the secretary. We've gotten some response, but that meeting has not occurred yet, because I think it's really important for the patients, for them to hear from patients and to hear their solutions as well. So Aiken talked about Senator Wyden releasing his blueprint for a Senate bill for drug pricing, and there were some good things in there. It seems that they are listening to some ideas. They are, looking at the issue of rebates. They do say that the Trump administration proposal is not the way to go, but they are looking at that. They also said that they're looking at, there's a lot of attention to Medicare in there, but they also say we need to make sure that out-of-pocket costs are limited in the private insurance market as well. And so I'm, and I think, looking at greater transparency as well is important, because all the system of PBMs and the rebates is really a hidden, system that we don't see. So I hope as we progress in these debates in Washington, around the country, that our policymakers will focus on what the needs of patients are, and that we really have to limit the amount of money that patients pay for their drugs. Because if it's too high, we know patients will not pick up their drugs. They won't adhere to their medications, and in the long term, it will not make our country healthier. So thank you.
Thanks so much, Carl. And now I'm going to hand it over to Steve Mulmaris, who's going to do a little Q&A with Carl and Aiken. And again, if you have questions, please put them in the chat. And I think Steve has some questions prepared, but if you have one that you'd like to ask at the end, I'm sure he'll open it up for that as well. Steve?
Perfect. Thanks, Ashley. I'm just thrilled to be able to lead a conversation both with Aiken and Carl. I'm Steve Marmaris. I am a colleague of Holly Snow at Amgen. My role at Amgen is advocacy relations and alliance development. So I just want to thank both Aiken and Carl for their terrific perspectives on HR3. I think we had some great some great points made by both. Aiken did a really tremendous job, I think, summarizing the timeline of how we've gotten to where we are currently. And Carl, of course, not only, I think, really underlining what the patient interest is in HR3, but also outlining, what are some alternative principles that advocacy organizations can look to as substitutes for HR3, knowing that HR3 really has some unintended consequences. So I think first off, I want to ask a question to Carl, and the question pertains to an element that Aiken discussed with HR3, and that's the international reference pricing component. I think a lot of attention has been given to this piece, and most in the industry and the patient community consider it to be, really the poison pill to the bill. And so I'd love, Carl, to get your reaction on specifically how the international reference pricing component of HR3 will impact patients. What's your analysis, and if you have any predictions for what could play out should this component be enacted into law?
Sure. So yeah, this issue has gotten, everyone's complaining about, and Donald Trump said it all the time. Why do we pay so much for drugs in the United States, and why are they so much cheaper in the other countries? So, hey, it's a good point, but I think there's some good answers. So, I said, gee, we don't look to other countries to price other items. Why are we doing it for just drugs? So I looked up the price of a loaf of bread in Germany and London, in England and France, and compared it to the United States. Well, I found out the average loaf of bread in the United States is $2.65. And then I looked at the other countries, and they're around $1.65. And so should we be telling the US bread makers that you have to pay $1.65? And I frankly think that the bread in Europe, especially France, is so much better. I would pay, $5 for a loaf of bread here. So it's just not the way the system works. And why are we looking at only drugs? What about doctors? What about hospitals? Well, they're a lot cheaper too in those countries. Should we be importing those prices into the United States? And things are just so different, in the comparing, go on and talk about, it's innovation in the United States, and that's true versus the other countries. But, I'm looking at the patient perspective that, patients in those countries aren't paying a lot out of pocket. So here they're going to, if they're going to import their prices from those countries, are they going to cut our cost sharing too from $8,000 or so to like $2 for prescription? So I just think there's a lot of holes in it. It sounds nice. And also a lot of the drugs in these other countries aren't available. I think I've seen analysis for HIV, for cancer, that, it's just a proportion of the drugs that are available here in the United States are available in the other, countries. So I'm sure Aiken could go on and talk about the impact on innovation, but that's my perspective from a patient. And then what's going to happen? I don't know. I think if hopefully more and more people will understand, how this just not makes sense, and it's not how we operate. And if we start doing it for drugs, what's next? And isn't everyone going to be afraid?
Yeah, it's a great point, Carl. I really appreciate the point about kind of the precedent setting nature of importing drug prices or importing prices in general, healthcare costs from other countries. So Aiken, I think that the question that I'd love to ask you is specific to the Medicare negotiation piece. I know you touched on this throughout your overview, and most recently in the Wyden principles that were released yesterday, you talked about how important its inclusion is as a deal breaker to Republicans. But could you maybe, for our audience here on the Zoom today, talk about exactly, what is Medicare negotiation in the context of HR 3, and what really is that talking point around a desire or a need for Medicare to negotiate drug prices? Because I think when we hear discussion in the media about HR 3 and drug pricing legislation, to me it always starts with this talking point around Medicare negotiating drug prices.
So I think I will start to say that when you can put something on a bumper sticker, it sounds like a really good idea until you unpack it a little bit. Mm-hmm. So the federal government being able to negotiate maybe sounds good in theory, but when Medicare Part D was first passed in the early 2000s, there were two provisions in there. One was the non-interference clause, and one was the inability for the federal government to utilize formularies. So from the beginning, in the heart of allowing the private sector to drive negotiation in the Part D program is really the genesis of all of this. So that is why when Nancy Pelosi became Speaker in 2006, because it was a majority, I would say, Republican initiative because of the private sector, but she didn't feel like it went far enough. It's almost like comparing like the public option to the ACA. You kind of want to keep going further. But at the end of the day, if you went forward in actual Medicare negotiation and what it is and just repealed it, the non-interference clause is, there's actually no savings there because there's no backstop. So first and foremost, you also have to remember that Part D plans are already negotiating through the various Part D plan sponsors. So negotiation is already being had. There's 20 to 30% kind of rebates that go back into the system, which help lower premiums. So when you lower premiums, all the seniors are happy. And I'll say that for the past 20 years, the average monthly premium for Part D plans has been about $30 and doesn't go up. So that's a lot of the reason why these PBMs are actually doing a good job in negotiating with companies and among the plan sponsors to make sure negotiation actually already exists. So why insert the federal government into this? So what I would say for the HR 3 and Nancy Pelosi's plan, this is what she calls negotiation. You take the price that the government sets based on an international reference price, and it's 120% of said international reference price. So take that for what it is. But if you do not agree to my price, then I will start taxing you at 65% of your gross revenues. And you will continue to do that by each quarter until you decide to agree upon my price, going up to 95% of your gross revenues. If anyone can tell me that's negotiation and not extortion, for me to use my mafia words, that's funny. So there is no real negotiation here. It is essentially the federal government telling you what they will pay or walking away.
Mm-hmm. So it's a lot more, it sounds like it's a lot more price setting than price negotiation.
There's no negotiation. You're correct.
Okay. So Carl, and I'll ask just maybe two more questions, one to Carl and one back to Aiken, and then I'd love to open up a question or two to the audience. So please put those questions in the chat box. So Carl, Aiken mentioned this really impactful and pivotal letter from 10 moderate House Democrats that was sent to Speaker Pelosi, really expressing the concerns about HR 3. And actually, one of the leaders of those letters was quoted as saying, HR 3 does not do enough for patients. It does not materially lower patient out-of-pocket costs, and it prevents cures they need. I think that quote is really a strong parallel to a lot of the points that you made, Carl, about the importance of any type of drug pricing initiative focusing on out-of-pocket costs, and this bill doesn't seem to do that. If you had the power to implement just one policy change, Carl, perhaps from the 5 principles that you laid out in your letter, which policy proposal do you think would be most impactful for patients' out-of-pocket costs?
Yeah, so I realize you want me to get down to one, but it really has to be a combination of both.
Okay.
And I think, limiting patient out-of-pocket costs, in putting caps and or at least requiring, if you do offer co-insurance in some plans, at least you have to offer co-pays and reasonable co-pays in some others. But as I said earlier, we have that in certain states, and it's just not working well enough because of the high deductibles. And so it really has to be coupled with it has to be outside the deductible. And so you really have to have both, I feel. And, the reason why we have copay assistance, from manufacturers and is because of high copays. And so that if we, resolve that issue, and I got my wish of plans have to offer reasonable copays, then that whole issue of copay assistance and copay accumulators will hopefully go away. But that would be my number one ask. And I'm pleased, that it's getting some attention. And listen, even Senator Clinton, when she was in the Senate, she proposed a bill to limit cost sharing. Senator Warren had a bill to limit cost sharing in the private market. So I think hopefully it will be incorporated in the bills in the end.
And if I could just jump in 1 second, I think what everyone should also remember is that every single drug pricing package out there, every single one of them, although it's very different depending on which bill it is, has a Part D out-of-pocket cap. And so I feel like that is one bipartisan thing that everyone in Washington has agreed upon, but it's just a matter of putting it in a package. And as well as Carl touched on this, what we call is patient smoothing, but to make sure that you only pay a certain amount each month. So if you have a very high cost of drug that you get in January, you can really, but take it through the rest of the year, you can pay for it through the rest of the year. And so, there are policies out there that, again, everyone agrees to, but then it's like, what else is in the package? And then that's where things kind of get more complicated. But that is one policy that I think everyone in this world would agree to, that is necessary for Congress to do immediately, that would actually help patients tomorrow if they could.
That's great. That's really helpful information. So Aiken, you touched a little bit on this in your presentation, but what would you say, and I know it's kind of muddy water here, so the answer might not be as clear as we would hope it to be for the purpose of this call, but from your perspective, what's next for the bill, or what's next for Speaker Pelosi in advancing it? And I think the most important question for those on the call is, how can advocates who have concerns about the unintended consequences of HR 3, how can they maximize their impact? Who should they be reaching out to? Are there coalitions they should be joining? Those types of next steps, I think, could be really helpful too.
So I think with the crystal ball on HR 3, and again, Nancy Pelosi is an amazing speaker, and she has the ability to get her people in line real fast. But making them take this vote, knowing that you do not have 60 votes in the Senate, kind of puts things in a different mindset. But then if you went down a reconciliation type pathway, you could pick and choose some of the policies that would fit into reconciliation, which is more like budget number type deal. And that could be how a significant drug pricing package would go through as egregious as HR 3. So I think as we continue to move forward, HR 3 is not dead. So as much as we think that it's kind of the momentum has slowed, we can never take our foot off the gas of how important it is to stop a policy such as this. And the major policy really is the negotiation from international reference pricing and pretending like that's what it is. Let's call a spade, it's not negotiation. But what can patients do? I mean, their voices are so important and way more important than anything from industry has to say. So when it comes down to targeting people, I feel like just continuing the drumbeat of the message, people always want to take care of their patients, period. Policies such as HR 3 essentially would eliminate hope. So I think the future hope are the future cures. So there's a vital transformation study that's out there that talks about if HR 3 went through, how many less drugs one would have over the next decade. And I think the number right now is 61, but that's kind of, from the methodical way that they did it. But if you think about what is out of the 61, what is the next cure that's not going to be part of that, or the next therapy for your disease that's not going to be part of that, you really can upend the entire system. So really talking about your own story. I mean, politics, as we know, is always local. Well, it's local until you have 500 Twitter followers, and then no one really cares anymore, and your ego's getting in the way. But that is what it is. But really, I mean, I feel like the patient stories are important, and talking to your legislators and just getting the word out. I mean, like, this is your hope in the future of your health, and that's more important than anything else. We appreciate all the partnership that's out there.
Yeah, thank you, Aiken, and thank you for referencing the Vital Transformation study, and really the modeling of the impact of HR3 on innovation. I just dropped that link to the Vital Transformation study that Aiken mentioned in the chat for anyone who's interested in taking a look at it. I see that we've received one question from the audience so far. It's, I think, a tough question. I'm going to pose it to both Carl and Aiken. It has to do with copay assistance, and I know, Carl, you touched on the accumulator adjuster programs and efforts to limit patient out-of-pocket cost responsibilities. The question is, if there is copay assistance, who pays what, and who's managing the overall flow of money? What do you all have any reactions to that question? I would say it's most linked, Carl, perhaps to your points, and maybe you can make a linkage to one of those 5 principles that you had mentioned.
Yeah, so I'm not sure if I completely understand the question. So if there's copay assistance, who manages it and how do people keep track? So yeah, that's all behind the scenes, and that the patients don't know or see. It starts at I guess when the doctor writes the drug, he recommends the copay assistance at the pharmacy, and the pharmacy then takes it from there and works with the insurance company and the PBM, and to make sure it gets covered for the drug. And so the question is, does it count or not count? That's something that the insurance company decides, and that's their own policy, or the PBM. And unfortunately, the patient is the one who's left out in the cold, because this, as I said, this is all done behind the scenes, and they picked up their drug, right? So they think that the copay assistance that they've been counting on from X company is going to pay for their drug. And so they find out then a couple months later that, it didn't count. And so it's really the insurance company that knows all of this stuff, and the patient is kind of not aware until it's too late.
Are there any other questions from the audience? I think we've got just a couple more minutes before we transition to our next aspect of the meeting, but I wanted to give those an opportunity to ask any other questions, and feel free to just open your mic and ask the question. You don't need to necessarily type it in.
And I know people have asked for the letter, and I'm going to send it to Ashley, who's going to send it out to people.
I would just raise a little bit of a technical question. I'm Erin Fry from Ultragenics. We talked about ERISA plans and how the Georgia bill is not applicable to ERISA plans. I'm not sure if everyone understands what an ERISA plan is. If some propensity of people say, yeah, I'm not quite sure, it might be helpful to define that.
Yeah, so there's the ERISA plans are the plans that are most businesses have. And they are, a lot of them are self-funded. They rely on outside insurance companies they contract with, but they're really the business plans, and they're not governed totally by the Affordable Care Act. And so they're different from the individual market and the small group market plans. And the insurance commissioners and don't have jurisdiction over those plans. And so that's why we need, something to have jurisdiction over the ERISA plans. But it's a start, and I think it helps build the momentum. We're up to like 12 states now in Puerto Rico that have passed these laws prohibiting copay accumulators, and I think that shows to Congress that the sentiment of the American people on these issues, and the patients at least. And I should say that most people do get their insurance if they're in the private market from ERISA plans.
Excellent. Well, on that note, I think we'll close this panel. This was a terrific conversation, Aiken and Carl. Thank you both so much for your time. Carl, I know you had to clear your schedule to be here, so I really appreciate you doing that. And we will follow up with some of the materials that were discussed on the panel, but thank you all for your time and attention, and I'll turn it over to Holly for the intro of Sarah from ACS CAN.
Great. Aiken and Carl, thank you so much for your insightful discussion about the bills before us and potential consequences. So thank you, and we appreciate your leadership in this area. Next, I'd like to introduce Sarah Dom. She is with the American Cancer Society Cancer Action Network, which a lot of us know as ACS CAN. She represents Alabama and Georgia as the grassroots manager. In this role, she works on local, state, federal advocacy campaigns aimed at ending suffering and death from cancer. She is a graduate from the University of Bama at Birmingham, and is currently completing her master's at Johns Hopkins Bloomberg School of Public Health. Sarah, thank you so much for joining us today. Welcome.
Yeah, thank you so much. Excited to be here. Thank you for that great introduction. I think maybe all of you or most of you are familiar with ACS CAN. Like Holly just said, we work to make cancer a top priority for public officials and candidates at every level, federal, state, and local. And we do this by empowering advocates, cancer patients, survivors, and their families, people like everyone on this call, anybody who just cares about these issues, as well as experts on the disease. And we amplify their voice in public policy matters and connect them with their public officials, and try to find solutions that'll help reduce cancer burdens. And one issue, of course, that's very relevant to everybody here, but especially to cancer patients, is COVID. So I'm going to talk about COVID and how this disease has affected cancer treatment for cancer patients and survivors. It has affected cancer diagnosis, and how we are trying to move forward and combat these influences. So to better understand the impact of COVID on cancer care, ACS CAN has put forth a Survivor's View survey. And to talk a little bit about what we do with our Survivor View survey, what we do is we have around 3,000 cancer survivors throughout the country, and they have agreed to participate in these surveys by responding to regular surveys on policy issues that support their quality of life, that affect them personally. Through this, we are able to hear directly from cancer survivors and to better understand their experiences. So the most recent Survivor View survey was on the topic of COVID-19, and we wanted to better understand their experience with cancer screenings, the disparities in access to cancer care, and to help best identify what public policies have the greatest opportunity to impact their lives. So this specific survey was a web-based survey. It was taken by 1,280 cancer patients and survivors between March 30th, 2021 and May 14th, 2021. So this is a pretty recent survey. The findings have been released recently. And based from this, I'm going to talk about three things that we have seen as the key findings from this survey. So the first finding regards cancer screenings. Cancer screenings is a critical component of care for cancer patients and survivors. But based on this survey, we have found that 1 in 6 respondents reported a delay or interruption in their recommended cancer screenings within the last 3 months. These disruptions have impacted both screenings for their primary cancer and additional cancers for which they require monitoring, so which they are at risk of getting. Screening disruptions are in most cases attributed to the impact of COVID-19, including logistical issues such as staffing shortages or lack of available appointments, and also patients' concerns about contracting COVID-19 if they were to go in for these screenings. However, nearly half of all cancer patients and survivors surveyed have not talked to their providers about what modifications can be done because of these delays. So if any, that they should have taken during the pandemic. So based on this, we can see that there is a delay as well as a lack of communications and a lack of modification in figuring out how to modify based on these delays and what a path to take forward. So this, of course, is a concerning thing to find out. So that was our first finding based on the answers to the survey. The second finding is that more than 1/3 of cancer patients and survivors report difficulty accessing care during the COVID-19 pandemic. So this is about 35%. And this was higher for younger patients. So younger patients are more likely to have encountered difficulties accessing care. That was at about 40% of those under the age of 50s, as well as those who have indicated their race as American Indian, an Asian, or Pacific Islander. That was 44% as well. And they were more likely to have encountered challenges accessing care. So we are seeing that there are barriers that these patients are encountering, and that these barriers seem to be higher for younger patients as well as depending on the ethnicity, and they are not being able to get the care that they need. And then the last finding that I'm going to talk about is about cost. The overall cost of healthcare was identified by over 1/3 of cancer patients and survivors at 36% as the most important challenge in addressing that needs to be addressed in order to help people with cancer. This issue is critical because it affects the ability to afford all the treatments and services needed by cancer patients and survivors. Further, nearly 1 in 10 respondents believe that providers' perceptions of their ability to pay for care limits the treatment options offered. This belief is stronger among racial and ethnic minority respondents, 11% of whom believe that this is true. So this is further shows the importance of what needs to be done as we seek to understand the impact of racism on cancer outcomes. So that was another important finding that we saw. And the truth is, when you add up premiums, high deductibles, copay, and coinsurance, the cost of cancer care can be really overwhelming. Especially for those with lower incomes. It's more evidence that policymakers should act quickly to make increased subsidies available to those buying private insurance on the exchange permanent, rein in junk insurance plans that leave patients at high risk for shouldering even higher out-of-pocket costs, and to do everything possible to expand Medicaid, especially in states like ours in Georgia. The pandemic has had a serious effect on cancer patients, and lawmakers need to do what they can to lessen the negative long-term impact by ensuring cancer patients can get timely, affordable care that they are able to access that allows them to have the care that they need. So ACS CAN Survivors View data is provided by cancer patients and survivors to give us a better understanding of their experience and opinions on cancer-related issues, and to give voice to cancer patients and survivors as we shape and move forward on what we need to do following the COVID-19 pandemic. So our Survivors View survey focused, as you can see, on current cancer patients and survivors, so people who had been diagnosed before the pandemic or during the pandemic. But another huge thing is that we know that the COVID-19 pandemic had a profound impact on cancer screenings across the US. And cancer screenings, we know, saves lives, and that timely detection of cancer has a profound impact on the outcome of cancer patients. At the beginning of the pandemic, we saw cancer screening rates decrease by nearly 90% for important cancers and high impact cancers such as breast, cervical, colorectal, and lung cancer. This is really worrisome. As the earlier cancer is detected, the more options that there are for treatment and the better the chances are for survival. So the fact that we are seeing less people being screened means less cancers are being found, and that these cancers are likely to be found later at more impactful stages of the disease. So this is a huge concern for the American Cancer Society, ACS-CAN. Also, we know that the COVID-19 pandemic also had another impact. An estimated 12 million individuals have lost their employee-sponsored health insurance coverage, with a disproportionate impact on Black and Hispanic people. So this is another huge issue that we know that if we want to fully understand the impact that COVID-19 has had on cancer patients, we also have to understand and account for the huge amount of people who lost their insurance and the impact that that would have on their rates of getting screened because they no longer have health insurance. There is, throughout 2020, we have seen cancer screening rates rebound somewhat into 2021, but recent reports show that there is still at least a 30% decline in the number of cancer screening tests compared to pre-pandemic years. So although we are not still at that 90% reduction and decrease, we are still lower. And people are still not going in and getting their screenings, and we are not at the rates that we would like to see and what we would expect to see if this was a normal year. So our main priority as we look forward, what should we do? What do we need to focus on is that we need to get people screened. We need people to go get screened, people who put it off, people who didn't have access to it. We need to figure out how can we go and get them screened. And we know the facilities are working to have COVID-19 safety precautions. Many our states are trying to put in place lower reduced cost screening programs so that people that don't have insurance or a primary doctor can be screened. But as I mentioned before, we are still seeing these rates at a much higher rate than we would want it to be. One thing that the American Cancer Society is doing is that it has launched a new Get Screened campaign to encourage people to get their regular cancer screening tests, especially in light of those that may have put it off because of COVID. This campaign seeks to help people understand what cancer screenings they need to have, what are recommended for them, when they should be getting them, and how their insurance covers it. There are resources, if anybody would like to see them or to understand more about this campaign, the American Cancer Society has created, as well as, of course, partnerships with different health systems to help people start or restart their screenings that they need to be getting. But of course, there are other things to be done, and at ACS-CAN, we are also always looking for policy issues and policy solutions. So another issue that we have identified as a high impact place to go is that we want to make sure that screening programs are fully funded. Specifically, a screening program that we advocate for is the Breast and Cervical Cancer Early Detection Program, which provides critical life-saving safety nets for low-income, underinsured, uninsured, or underinsured women so they can get cancer screenings and early detection services. For those of you who are not familiar with this program, the Breast and Cervical Cancer Early Detection Program is a comprehensive cancer control program funded by the CDC as well, and it is from the local, from the state, and also on the federal level that has effectively provided breast and cervical cancer screenings, follow-ups, diagnosis, and treatment for disadvantaged and diverse populations of women. The program has been in place since 1991. It has provided over 15 million screening exams to more than 5.8 million women. And women eligible for this program would not have access to these screenings without it. So it is an essential program, and it is something that ACS can strongly support. The ongoing COVID-19 pandemic and resulting unemployment and loss of health insurance coverage is likely to increase the amount of women that are eligible for this program, as well as the need for screenings throughout the country. We don't fully understand what the impact of COVID will be fully, and this economic downturn will be on the program. But we do know that in previous recessions, there was an increase in the number of women eligible for the early detection program. So we expect to see similar increases now. So we are concerned that the state budgets will be under pressure due to the economic impact of COVID-19. And this pressure will result in cuts of funding, eligibility, and benefits for services of this program, just when we think that they're most needed. So we are concerned that the program will not be funded fully and will have a decrease in funding. We know that it is highly effective at detecting and treating breast and cervical cancer. However, it is currently underfunded already, and it cannot provide services to all eligible individuals. In fact, we currently see that of those eligible, less than 1 in 10 women receive cervical cancer screenings, and less than 2 in 10 receive breast cancer screenings. So these numbers are already low, and as more people become eligible for the program, we need to see an increase in funding, not a decrease. So that's why, as an advocacy organization like ACS can, that's where we come in, right? That's where we are able to come and advocate for adequate funding for the breast and cervical cancer early detection program at both the federal and the state level, as well as preservation of Medicaid eligibility for individuals diagnosed with cancer through the screening program. We strive as an organization to identify those affected by this program and put them in a position that they can share their story with lawmakers, and that we can work alongside advocates to reach out to the Congress members and ask them to fully fund this critical program. And this is one step that we are taking to try and minimize as well as help with the effects that COVID has had on cancer rates and increased screenings. But the truth is we don't know the full impact that COVID is going to have on cancer rates moving forward. And we won't know for many years. There's just no way of knowing right now. But we do know some things. We know that there has been a decrease in screenings. We know that that has happened. And we know that screenings are essential to effective care and diagnosis of cancer. And we also know that many people have lost insurance, and that losing that insurance means that they will not be able to get the care that they need, or the screenings that they need, or the continued treatments that they need. So these are all very concerning for us as an organization, and we don't know how that is going to affect long term, but it doesn't seem good. But we do also know a few things that we can do to help those that are impacted. The funding of the breast and cervical cancer early detection program being one of the priorities that we have, as well as seeking to expand Medicaid in states that we can, making sure that people are able to keep the coverage that they have, and helping the people that have found themselves without insurance or with reduced insurance because of loss of jobs. So that's where we are as an organization right now. I hope that this has been enlightening and given you a little bit of a perspective on what cancer is looking like. I'll be happy to share any of the information. I have links for the survivor reviews, as well as the Get Screened campaign, and information about our advocacy work that I will post in the chat box, as well as, of course, if anybody has any questions or wants to learn more about anything, please feel free to reach out to me. I would love to hear from you.
Thanks so much, Sarah. And if anybody has any questions, I do see we have one. I think Dorothy addressed it, but I will pose it to you, Sarah, as well. Aaron Fry asked, do you have any knowledge yet of effectiveness of COVID vaccinations on cancer patients? Does their immune system being compromised mean that the vaccine is not as effective for cancer patients?
To be honest, I can't really speak to that. Right now, I would say to follow physician guidelines on that. We are, of course, trying to be careful with any exposure that we have for our volunteers and with anyone that we have that is a cancer patient, because obviously their immune system is especially susceptible to COVID-19. And that's been something we've been very cognizant of throughout the pandemic. But I cannot I cannot speak in detail to that.
It looks like you got one more. Holly Snow asked, Sarah, can you discuss ACS CAN's initiative to support state legislation cancer screenings using biomarkers?
I'm not sure if Holly, you can jump on to this. I'm not sure if that's something we've been doing as much in Georgia here. That may be, you might have to jump onto that. I don't really think I know as much about that.
I guess the question was, I know that ACS CAN has a national initiative targeting select states to where there have been barriers of patients being able to get access to biomarker testing to further determine the type of cancer so that the treatment can be precision driven. And I didn't know if you could speak to that. And I don't think Georgia was one of the states, but just didn't know if you had any other perspective on that.
No, and I'm happy to follow up with you if I can. I think that's really great, but yes, unfortunately, when it's not happening in my states of Alabama or Georgia, I don't always know the details. But I'm happy to follow up with information about that. I'm sure I can get it.
Thank you.
Excellent, Sarah. And I know Sarah mentioned a few links that she was going to pass along as resources. I think she's going to maybe put them in the chat and also send them to me, and I'll include them in the follow-up email. And I also already have Carl's letter, so I will include that in the follow-up email as well. All right, well, now we are actually going to transition to something we're very excited about. I'm going to hand it over to Dorothy to talk about the new Patient Advocacy Alliance webpage on the Georgia Bio site. So Dorothy, take it away. Oh, you're muted.
We are excited about this, and I'm going to be quick because I want to leave some time for the audience discussion, but Georgia Bio has given us a great opportunity to have a tab on their website under their advocacy listing, and we are going to be able to present a blog and to inform all of you about upcoming events, our scheduling, and any information, any advocacy alerts, anything that we're moving forward on so that you can all participate. And what we did to showcase this and to bring the life sciences and the patient advocacy community together, in our last meeting, we were talking about living with a chronic illness. And some of our advocates said there's so much that people don't know about chronic illness, including medical professionals, caregivers, and the general public. So I interviewed a patient advocate and patient himself, Corey Lewis, who is the director of the Red Moon Project. And Corey has been a wonderful support for what we're doing with Georgia Bio. And he told his story about what he needs people to know about chronic illness. So we have that blog available. I hope you will all go and visit it. And in the future months, we're going to write more about what you don't know about chronic illness that you should know. And we'll be interviewing other patient advocates to be able to give you their perspective. We're also going to be, as I said, posting our schedules. Remember that we have a roundtable meeting again like this in December, and then we're getting ready for our big summit in September, where we feature issues that are really important to patient advocates. Our goal is always to amplify the patient advocate's voice, and that's what we hope to do on this site. So we're going to address economic burdens, just the access burden of having prescription drugs and treatments, the interactions with physicians and other medical professionals, while we are also giving tips and hoping to reduce the disparities in our healthcare system and the cultural incompetency that we all face every day. So our first entry is up there. Please give it a look and give us your feedback. And we thank Corey for being the first person to step up and say, yes, I'll tell my story. And I hope that this will help. So keep looking at the website so that you'll see our current postings. And also remember, all of you that are on the call, all of our advocates for you and your members, membership at Georgia Bio is free. They have opened it up to us to really show that we are going to be partnering together. So please consider membership. Go on the site. It's very easy to become a member of Georgia Bio. And this way you will be able to know firsthand what is happening. They have a great newsletter that comes out, and we look at it all the time at Advocates for Responsible Care. And this will be a way in which to really increase our partnership together. So that's what I wanted to let you know, is that we're going to be talking more and more about advocacy strategies and how we can enhance this partnership together and bring all of you as patient advocates on this train with us.
Thank you, Dorothy. And I believe that Ryan put the link to the new webpage in the chat. We'll also include that in our follow-up email as well. And Corey, we are very grateful for you for sharing your story, and grateful to Dorothy for typing it up and sharing it with us. It's wonderful. So please go give it a look. Also, this is still a work in progress, and we want to know what you want to hear. If there's information that you would like to be included on this, if you think that there are helpful resources, please let us know. This is only as helpful as you find it helpful, and we want to make sure that we're listening to you and providing the information that you need. And with that, we have about 10 minutes left. I will turn it back over to Steve for our open discussion. This is where we hear from you. So.
Yeah, thanks, Ashley. And wow, we've really covered a lot of ground today. We've gone to Washington, D.C. We've learned about HR 3. We've come back to Georgia and had a great presentation from Sarah on the impact of COVID-19 on the cancer community. And then we've learned about some really great advances in our resources that we're offering through this terrific coalition. So I think what I'd love to kind of open up for conversation here is, what does everyone think? Was this a helpful meeting? Are we headed in the right direction? Is this the type of information that is useful for you? I know we have a lot of Zoom fatigue these days, and we certainly don't want to just add meetings for meeting's sake to people's calendars. So we hope we're delivering value to everyone. Of course, this is a group and a forum that we hope to bring together as really a great opportunity for industry and for the patient and provider advocacy community to come together and discuss some of the most critical issues at hand. as Amgen, at Amgen, we kind of, Holly and I stepped up to really kind of be the first supporters of this and hopefully kick it off in a strategic direction. But we fully intend at some point to, rotate off of this steering committee and have our peers rotate on. I want to underline the fact this is not an Amgen, driven initiative solely, and this is a collaborative initiative across all of our industry stakeholders. But would love to get people's reflections, opinions on where we may go next with this, and was this the type of format that was valuable to you? Don't be shy.
We'll actually put mine in the chat. Mike Predis with Genentech. Thanks, Amgen, for putting this on. Georgia Bio, I've always enjoyed being a member of Georgia Bio for the many years that I have. So again, I think this information is always great. We as an industry, and when I say industry, I'm talking across the broad spectrum that includes patients, healthcare providers, hospitals, pharma, bio. I mean, we all have a lot at stake in the future of this country and where we're going with respect to innovation and some of these difficult political issues that we all face, right? I mean, getting medicines and innovative therapies to patients, how do we pay for them? How do we keep, the costs down across the board? It's not just one segment. As Aiken had mentioned, it's a lot of segments of the healthcare industry, and we have to have these types of forums and these types of discussions so that we can come up with broad-based solutions, whether it's HR3, HR19, or some hybrid in between at the federal level and at the state levels. This is great. I'm glad that we're doing it, and I think we should continue to do it.
That's great. Thanks for the feedback, Mike, and some really great points you made there.
I'd also agree that the format was good, that it got deep enough to have a conversation. And then I like the idea of being able to ask a few questions, clarifying questions. In my case, particularly, I think it's great that we want to get the care out and the communication, and then we can find some way to balance who's paying for what. Because somebody's, the whole medication issues, how much is the manufacturer getting out of this, and where else is the money lost along the way?
Yeah, that's a good point too, Hal. And I know that is absolutely, number 1A on the future agenda list, to have a deeper dive into the reimbursement landscape and really breaking down, I think, for the patient provider advocacy community, our complex coverage and reimbursement ecosystem. And I will definitely lean on you strongly, Hal, when we finally do cover that topic, with the attention that I know you want to cover it with. So we have not forgotten about that topic. That is front and center for us, and we'll get there.
Oh, no concerns. I thought it was a great conversation, and just the fact that it came up in and out was exactly what I would hope for, is that people realize there's some really great medications and really great accomplishments. We got to both get the patients thinking about what they got to do too, helping them get some ownership, that engagement issue.
Absolutely. Great. Well, I see a lot of new names on our list here that I haven't seen before. So I would love for someone who maybe is joining for the first time to give your impressions, or talk about maybe what some of your interests are, either from your company perspective or from your nonprofit perspective. Would love to get some new infusion of perspectives if someone is brave enough to take that on.
Yeah, hey, Stephen, I'll jump in here. I'm certainly brave enough. I'm Bob Hartman. I work with J&J, so I work with Ashley Groom. This is my first time attending your meeting. I live here in Georgia. We got here about 6 months ago from the Northwest. So I used to work with Washington Bio up in that neck of the woods. I will say now being in Georgia, go Hawks, beat the Bucks tonight. So
Nice.
we'll keep our fingers crossed. We've been to a couple of those games with my son and I since we've been down here, but a lot of familiar faces that are on the screen here. Dorothy, I look forward to meeting you. I work hand in hand with Scott Willett very closely. So no, I thought the content, as I put in the chat box, Stephen, was very robust. A lot of the hot issues that you went over and topics that we have our pulse on here at J&J. And as I know you do here, there at Amgen as well. So, you know, again, anything that we can continue to do for access for providers and patients is kind of our key goal.
Awesome. Well, welcome, Robert.
Thank you.
Really look forward to, you know, you joining our planning calls in the future and leaning into this group. And I'm excited to watch some more Trae Young tonight too. He's been an exciting player to watch. So great.
Thank you.
Anybody else?
I'll pipe up. I'm new to this group. Erin Fry, I'm from Ultragenics, and we're a rare disease treatment innovator company. And so the concept of chronic disease is true for rare diseases too. And so I think that this has been super helpful. The first thing that I want to say is praise God for Dorothy, because it was her conversation that got me here. And I think that just the enthusiasm that she spoke of is clearly represented in what I heard today. Aiken, I think your description of HR3, even for someone who's been entrenched in policy, was probably the best and most succinct and clear description I've heard of that journey in my whole life. So I really appreciate that. And Craig, I'm just fearing I got his name wrong. God help me. Carl, I'm so sorry. Your articulation of the patient's point of view and those 5 things, like, I'm dying to get my hands on that document because, you know, I'm sure we're all very committed to the patient perspective in this issue. And knowing, you know, straight from your mouth representing a number of advocacy groups, what you said I know that will help our policy people as we're continuing to hone our talking points. So, you know, to the extent that anyone ever wants, and it is appropriate for industry to sign on to those kinds of things, count me in. I mean, I think that patient perspective is something, especially for those who deal with chronic diseases, is so important for us as biopharma representatives as well.
Yeah, totally agree, Erin. I think Aiken and Carl had to jump off, but we'll absolutely convey the sentiments that you said. You know, I agree. I think really the importance of Carl's letter, and I think the reason why we really wanted to get him on to talk about it is a point that Aiken made too, which is, you know, we can't, as industry and as a patient provider community, just be the voice of no when it comes to drug pricing and affordability. It's a real problem for the country. It has to be addressed. How do we get there with a solution that works for the patient and their out-of-pocket costs? And so I think what Carl's letter really represents is some alternatives and, you know, something to offer back as a response, which of course is a really key part of a negotiation, you know, and we want to have a negotiation. We don't just want to be a blockade or be seen as a blockade. So if there are no other questions, then I think I might turn it back to Ashley and we can close this out.
Come in with one thing. I'm sorry. I want to just come in, and I don't want to put her on the spot for her to have to show herself, but our dear friend, Jeff Cornett, who's been running Hemophilia of Georgia forever and helped me start this connection with Georgia Bio in 2012, is retiring. And his right-hand person, Michelle, who's on the call here, is taking over as of next month. And we just wanted to welcome her and acknowledge her because she's going to be a great force as an advocate, just like Jeff has been. And we wish Jeff the very best. He's been a great trailblazer with me. And I just appreciate him always being there.
Thanks so much, Dorothy. I really appreciate that. And obviously we'll pass along that message to Jeff. I actually don't have my camera on because I am running into another meeting as we speak, but I'm very excited to be talking to this group. I just wrapped up with Georgians for a Healthy Future, so I'm pretty familiar with other folks on this call. And yeah, I'm taking over as the new Senior Director of Advocacy here. This was an incredibly informative call, so I'm really looking forward to taking more time to speak to each of you. I think that you all should have my contact information after this, so I'm more than happy to, start meeting everyone and get more involved. Thanks so much.
That's great. Well, congratulations, Michelle, and thank you, Dorothy, for highlighting that. And I'll turn it over to you, Ashley, and we can wrap up. Thanks, everyone, for your attention.
Excellent, Steve. Thank you. Thank you to all of our speakers. I think this was excellent content. We're already getting lots of positive responses in the chat, and it's good to know that we're on the right track here. As I've said about the webpage and about everything, this group is only beneficial if you find it beneficial. So hearing from you and making sure that we're addressing your concerns and your desires is top of our list. We will get more information out about the Patient Summit probably in the next few weeks, so be on the lookout for that. And I will also send a follow-up email once we have this video posted to our YouTube page, so I'll send that link, Carl's letter, the links that Sarah shared, and Leanne, I see that you shared some information. I'll share that as well. And again, go check out the website and let us know what you'd like to see on there. And if that's it for today, thank you,
Ashley,
everyone.
I got a quick question.
Yeah, sure.
So if we registered via our email, then do you have our email to put on that distribution list?
Yes.
Okay.
We're going to take the list from the past 2 events and the Patient Summit last year, and that is going to be our Patient Advocacy Alliance list. So if there's someone else who would like to be on that list, just tell them to shoot me an email and I'll get them plugged in.
Will do. Thank you.
Thank you. And thank you, everyone. We look forward to seeing you in September.
Thank you.
Thank you, Ashley.
Thanks.
Bye.